Friends, welcome to my workplace for hands-on Phaco and SICS training. Let us observe this totally unedited surgery. This is a cataract with grade 4 nuclear sclerosis. This is the main incision with a 2.8 mm steel keratome on the posterior aspect of the limbus. A side port is made on the right side of the main incision. Another side port is made on the left side of the main incision by the keratome itself. The side ports are 3 clock hours away from the main incision. An air bubble is injected to fill up the anterior chamber. Beneath this air bubble, trypan blue dye is applied over the anterior capsule. And now, the dye is washed out with a 23G Simcoe cannula, and then the anterior chamber is filled up with 2% hydroxypropyl methyl cellulose. And now I am doing capsulorhexis with the help of a Utrata forceps. I raise a capsular tag, guide the tag anti-clockwise all around, and get a rhexis of about 5.25 mm. In hard cataracts like this, the size of the rhexis should not be less than 5 mm. Hydrodissection is done with a 27 gauge cannula. The nucleus is tapped. The nucleus is rotated. And then the anterior chamber is again filled up with SPMC. And now is the time to apply my submarine chop technique for this hard cataract. The Phaco needle goes in with its bevel down. Some superficial cortical lens matter is removed. Now the handpiece is turned and the bevel is made up towards the cornea. Now the tip is buried in the substance of the nucleus. It goes through the substance of the nucleus as a submarine moves through water. And I get a nice crack. Rotate the nucleus and get another crack, and 2 heminuclei are obtained. Then each heminucleus is subdivided into 2 pieces. This is a real-time video. And now each nuclear fragment is tilted. The Phaco needle is placed just under the apex of the piece and they are emulsified. 3 pieces are emulsified. Ultrasonic energy is set at 80%. Flow rate is 45 ml per minute. Vacuum is 450 millimeter of mercury. This is the management of the nucleus. Very little cortex are remaining in this case. Little bit of visco. Now I take the Simcoe cannula. Before that, I am enlarging the main wound because I am going to use a B cartridge for implantation of the intraocular lens. So the size of the main wound is about 3 mm now. And this 3 mm wound helps in removing some nuclear pieces, small nuclear pieces. So the cortex is being cleaned by the 23 gauge Simcoe. I use a glass syringe to create vacuum with my left hand. And now is the time to polish the lens. This is hydro polish. I use the irrigating probe only to polish the posterior capsule. Hydroimplantation of a monofocal intraocular lens has been planned in this case. And before that, some amount of polishing of the anterior capsular rim has been done by the Simcoe cannula. And now here goes the irrigating cannula through the side port, and the intraocular lens is injected in the capsular bag. The leading haptic goes in the capsular bag. The trailing haptic is gently pushed, and by the push of the left hand instrument to the haptic optic junction, the trailing haptic goes in the capsular bag. The lens is dialed by the irrigating probe. And now this is a bit of moxifloxacin. The side ports are closed by corneal stromal hydration. And then a final lavage of the anterior chamber. And the anterior chamber is nicely formed, and the integrity of the wounds are checked, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence. Please learn the submarine job technique. Cornea is clear next day because you apply all the ultrasonic energy within the substance of the nucleus, and the energy doesn't reach the corneal endothelium.